So oftentimes the uncertainty around healthcare provides a lot of anxiety for people living with various diseases, including osteoarthritis. And one great way to demystify this and to reduce anxiety is to get a little bit forewarned and forearmed about your experience with healthcare. Today's episode of the Joint Action podcast is really trying to demystify the first part of your clinical journey, specifically engaging with healthcare professionals, going through and telling them your story of living with this disease, having a physical examination, and ideally from there, formulating an appropriate, individually tailored management plan that suits and is made in a shared way, targeted towards your goals. So those first parts of the history, your story of living with osteoarthritis, are really important for you to think about in advance of that health encounter so that you can go along and ideally provide answers that would be reflective of your living with this disease, the impact it has on you, and ideally share meaningfully in the formulation of goals for the management of the disease. From there, after a detailed holistic history has been taken, ideally a tailored physical examination is then done to try to determine where your symptoms are coming from and the functionality of your joint. It's only then, typically, that you would then move on and formulate a management plan that ideally, again, is a shared one where you, as the person living with osteoarthritis, share that development of the management plan that's targeted towards your goals with the health professional that's looking after you. So it's those details that ideally you should go along to the health encounter forearmed and forewarned with so that you can get as meaningful an encounter done as possible. And we're privileged to have today two wonderful physiotherapists, Melanie Holden and Pip Nicholson, to talk through this really important topic. This is on the back of them, along with Letitia Devisa, contributing to the development of a module to help train healthcare professionals in communication related to history and physical examination for osteoarthritis. Hello, Mel, Pip, welcome to the show.
Hello, David.
And I should have not said Mel, Pip. I should have said Mel and Pip, but that's okay. I'm sure everybody will understand by the time we get to this end of this conversation exactly what's going on. But in the first instance, Mel, if that's okay, can you just share with the listeners a little bit more about your background and what a typical day looks like? And this will be an old question for you because I've obviously asked this the time you were before on the Joint Action podcast, but some of the listeners may have forgotten your answer, so go ahead.
Yeah, so I'm a physiotherapist by background and I work at Keele University now in the School of Medicine. I'm a professor of musculoskeletal rehabilitation and I do lots of research focused around osteoarthritis and how best to treat people with osteoarthritis, mainly through non-drug treatment.
Wonderful. Thank you for sharing that again. And Pip, how about you?
I'm also a physiotherapist by background. I trained in New Zealand, worked solely clinically for 5 years in New Zealand, the UK, and then in Australia. And then I moved into a research role, firstly at the University of Melbourne, and then undertook my PhD. And then I've been here at the University of Oxford in the Nuffield Department of Orthopaedics, Rheumatology, and Musculoskeletal Sciences for almost 6 years now. And similarly, my research is focused on hip and knee osteoarthritis, both non-operative treatments, but also trying to optimize outcomes after joint replacement and joint revision surgery as well.
Wonderful. And obviously you're in the UK now. And before we got on and started having the recorded conversation, you mentioned something about the brilliant weather that you're experiencing. Given you're from Paradise, would you have been better off staying in Paradise, namely New Zealand, before you moved to the UK, or are you happy?
Oh, it is something that I contemplate, particularly when it's raining and I'm cycling up the hill to work. But no, I'm very happy to be able to visit.
It's a little bit tongue-in-cheek because I know obviously both Mel and Pippa are both in the UK at the moment, and I'm sure loving the experiential component of the weather that the UK provides everybody very, very generously. But before I digress too much further, obviously today we're talking about a critically important part of the patient journey, that of the encounter with health professionals, and specifically what health professionals ideally should do in engaging with people living with osteoarthritis. And in typical parlance, oftentimes that encounter is divided up into the story of your osteoarthritis, what we might call a history. Subsequent to that, typically there's a tailored physical examination. So, there may be laying on of hands to try to determine exactly what's going on within the joints that are involved in other parts of the body. And then from there, potentially there'll be a need for further investigation, and hopefully, ideally, a shared management plan is developed. But the first part of that particular encounter is identifying your story. So you're really working out what your history of osteoarthritis is. So I guess in the first instance, Mel, why is that important?
Yeah, so it's really important for a healthcare professional to ask the person lots of questions to really understand what's going on. So, for example, if someone came to see the healthcare professional and they were a certain age and they're presenting with knee pain, well, that knee pain could come from lots of different sources. So it could be osteoarthritis, but it could be something else. So it could be a sprained muscle, it could be a torn ligament. And so we really don't know. And so that's really one of the reasons why we start asking a person lots of questions to really work out what's going on, what's causing the pain. So it's important to know what the pain is. It's important really to rule out if there's anything else that's more serious going on as well. So, for example, if there's a fracture there, if there's a tumour there, it's those questions that will really start to unpick that. So there'll be lots of questions asking about symptoms that might feel relevant, but some might not be. But again, those questions will be really geared to working out what's going on, but also to get to know that person as an individual rather than just the symptoms. So you might find that you get asked questions about your sleep, about your mood, about your kind of social activities. And we're really asking that, again, just to help understand the impact that the pain and the symptoms can have on your life. But these things are really kind of interlinked. So the symptoms might be causing issues with how you're feeling in terms of your mood, but also mood can affect the symptoms. So that's why it's really important to get a kind of holistic assessment to get to know the person, and that can help then tailor that individual treatment for that person, so it's the right treatment for the right person.
Wonderful. And within that, obviously you might go on and look at further aspects of the history taking in that holistic assessment. What aspects, you've touched upon some of this in terms of that being a holistic assessment, but what aspects of that history taking other than that holistic assessment are important to cover there? And I guess I'm particularly wanting you to expand on aspects related to the impact that it has on a person, the goal setting pieces, and how that might lead into subsequent management plans without leading you too far.
Yeah, no, that's fine. So obviously be asking about the kind of symptoms, so that the history of the symptoms, what people are doing to try and help. But there'll also be questions around other healthcare conditions, so other health problems that somebody might have, because that might affect, particularly around medications, for example, that might influence what treatments you can have. Thinking about somebody's mood, thinking about their confidence, their attitudes and beliefs, so what they feel is going on with their knee problem, what they think about potential treatment, so how they feel about an exercise program or a weight loss program, for example, how they're sleeping, because that can be important. So pain can affect sleep, but sleep can also affect pain. So it's really kind of thinking about all of those quite broad things, really, to get that overall kind of picture of that person.
And when a health professional does that, ideally, what type of communication style should they adopt that would allow them to get the best information from this?
Yeah, so really we're trying to encourage a kind of a person-centered approach to communication. So being an active listener, so really listening to what someone's trying to tell you, trying to focus on open questions, try not to lead people. Because if you say, oh, for example, well, you take pain at night time, don't you? So that person will probably say, well, yes, I do. But rather than, so it's around the style that gets the most information out of somebody. But as well as that kind of verbal questioning, we're also looking for non-verbal cues as well. So how people are kind of looking in their face, and that can give away a lot as well. So it's really focusing on both the verbal and the non-verbal.
Yeah, and obviously an important part of that conversation, coming back to the comment that you made about this being person-centered, is trying to identify the goals that a person may have related to their condition. How, as far as the story is concerned, how do we go, or how rather should health professionals go about doing that in a way that is truly person-centered rather than just what the clinician wants that goal to be?
Yeah, so it comes back to that communication style, that kind of active listening, and then it's working together with the patient to work out what they want, so what they expect out of treatment, what they want to do. So it might be, for example, that they can't take part in an activity that they like to do, like gardening, for example, or bowling or dancing. So then it's saying, okay, that's your goal. Now, how can we achieve that goal? What can we do to get you back? And it might be some strengthening exercises. It might be some kind of increasing physical activity or pacing of activity. So it's really working out what's valued to the patient, and then working out as a therapist, well, okay, what are the tools that we can use to help you achieve those goals? I think when we're thinking about goal setting, we tend to think about them in terms of SMART goals. So they're quite specific, measurable, so they know they can be measured and we know how well we're doing with those goals, achievable, relevant for that person, and timely. So it's being very specific about the goals, but a goal that's important to the patient.
Yeah, and I think that's obviously key, because at the end of the day, for a person with osteoarthritis, engaging in a management plan that may involve important changes in their behavior, motivation is often difficult, particularly if it's a goal that they haven't set themselves. So that's obviously a really key and essential point. Mel, is there any other really key parts about that first part of the history that you think it's important that we cover off?
No, I don't think so. I think we've covered most of it, but I would just say, even if the questions don't feel relevant, so they're not specifically about your symptoms, they still are important. So it's just kind of go in expecting to answer a wide range of questions about yourself, just for the reasons that we've talked about, really.
Yeah, no, I think, as you say, it's really important that be holistic and cover a whole lot of elements that in the first instance you may not necessarily think are immediately relevant to the management of your condition, but hopefully it all helps in building a really important story about your experience of living with that disease, the impact it has on you, and hopefully that helps to inform some shared decision-making and goal setting between the person who's living with osteoarthritis and the clinician who's caring for them. Now, Pip, moving to you, if that's okay, what I might get you to, okay, is tell us about the next phase of that journey with the clinician, specifically around the physical examination. Why do we need to do a physical examination for diagnostic purposes in osteoarthritis?
So the physical examination really allows us to build on the history, on what we've been told, what the person has said about their symptoms, what they have trouble with. So doing a physical examination, it means that we can actually look really closely at the specific elements of that. And it's just really important to clarify something that people, a sort of common misunderstanding, is that to diagnose osteoarthritis, that you need to go for an X-ray, that you need to have an X-ray to be able to diagnose. That's not the case anymore. We know that we can accurately diagnose osteoarthritis from a really good history and the physical examination. We really can break the physical examination down into 4 parts, and the clinician might first of all look at you moving specific joints, but also just at how you're standing, how you're sitting, how you walk in and out of the room. And then they might move on to feeling perhaps the joint. So looking at the joint specifically, and they're looking for tenderness or bony enlargements or heat, anything that might indicate some changes within the joint. And then the 2 other parts are looking at you at you moving and measuring as well. So we're looking, when we say moving, we're looking at how far you can move that joint, but also the joints either side. And similar to the history, within the physical examination, there might be some parts that you think, oh, but it's my knee that's sore. It's not my hip. Why are you looking at me moving my hip? But it is really important that we look at the whole body to see, so that we can actually really see a good picture of what's happening. So the physical exam will include sort of multiple different parts, and the measuring part that I mentioned might involve you doing some specific tests, so what we call functional tests, so things like perhaps standing up from a chair multiple times. We might ask you to walk up and down some stairs. We might also look at your muscle strength and muscle length, and also some joint specific tests. So there are some tests that we might do that are specific to the perhaps the knee joint itself that we're looking at.
That's a tremendous explanation. And really, just to emphasize a couple of key points, and I'll ask both Pip and Mel to comment on this. But in the first instance, one thing that you said, Pip, there is really just emphasizing the fact that it is a clinical diagnosis. So this is a diagnosis of a disease based upon the history that Mel explained and the examination that Pip just explained. And we don't need imaging in the vast majority of instances to make this diagnosis. Unfortunately, a lot of health professionals have a predilection to get imaging, but oftentimes that's not necessarily helpful in the grand scheme of things. And I guess another point that Mel, that you made, and Pip, that you explained, is that there are a lot of sources of pain in and around the joint that are not osteoarthritis. And without a proper examination, you will not necessarily know that they are there. And so there I'm particularly thinking about sources of pain like a bursitis, a tendonitis, particular muscle problems in and around the joint that you may get an inclination from a good history that could be the case, and then that's reinforced by a tailored physical examination that that's the case. But in the absence of doing that properly, if you went off and, for example, did an MRI in the first instance, you may make completely the wrong diagnosis based upon an image where you hadn't taken a decent history and physical examination. But, you know, in the worlds that you work in, Mel, I might just get you to comment first, if that's okay. Is that a frequent occurrence that the person goes off and gets imaging done, they get led down a path that's not necessarily relevant to the symptoms they're experiencing?
I think yes. I think that X-rays are still commonly done, and like you both said, we don't need to now. But I wonder if that's in part driven by patients wanting to have an X-ray as well. So it is just making the point that you don't need it. We can get the information that we need from the history and the exam. And what you were alluding to, David, is that even on the X-ray, sometimes there might be symptoms on an X-ray or some changes on an X-ray, even if someone didn't have any pain. So they don't always kind of marry up. And the changes on the X-ray, particularly in the kind of earlier stages of osteoarthritis, it wouldn't change the management plan anyway. So we really don't need to have that X-ray to make that diagnosis and to inform the management plan, particularly when we're thinking non-surgical treatments.
Yeah. And Pip, I'm obviously have a strong predilection towards favouring physiotherapy as a musculoskeletal practice. So I'm going to start with that at the outset for this particular question. But, you know, I think as far as learning about these specific techniques, whether it be the history or the techniques of physical examination, it takes time, it takes practice. In your experience, you know, how long did that process take for you and or your colleagues? You don't necessarily have to mirror it based upon yourself, but for your colleagues. And, you know, for most health professionals, is that an experiential learning process? Is it something you learn in a textbook? Is it something you learn by listening to this podcast or watching your Atlas modules that you've just created? What's the best way to do this?
I think it's a real combination of those factors. I think certainly when you undertake your physiotherapy training, you learn all of the tests, all of the steps that you should take, but it's through experience, it's through seeing patients that you're able to refine that, combining the history and the physical exam, and really learning to pick up on things within the history, within the discussion you might have with the patient, that you then can focus your physical exam. I certainly recall myself when I first graduated, I would do every single test that I possibly could because you didn't want to miss anything. And I think the more experience you have with patients and the more confidence that you have, and that may come through doing perhaps additional training, or just seeing more and more patients, that you're able to refine that down so that your physical exam very closely links to what someone has said in that history and links to what their goals are and what they want to be able to achieve.
Yeah. And, I think what you've explained is typically what I think for most health professionals, they generally experience. And so in the first instance, they're very recipe based and they follow a specific order about the way they do everything. But, over time, hopefully with greater experience and greater understanding of particularly the common presentations, but at least efficiency as well, you may tailor that more. But I guess a key point, and you've both emphasized this through tonight's discussion, is that everybody who presents is an individual and they present differently. And it's really important that, I guess the recipe-based approach to history taking and physical examination over time ideally molds itself according to the way a person is presenting both in their history and their physical examination, so that you can fully understand truly how that unique individual has discrete elements that just pertain to them. So Mel, is there any one piece of advice, knowledge, or wisdom that you'd like to give for people living with osteoarthritis?
I think really just reflecting on some of the conversations that we've had today is just that kind of reinforcing the fact that a healthcare professional doesn't need to have an X-ray to be able to diagnose osteoarthritis.
Yeah, no, it's a really good and valuable point, and hopefully more people sit up and take notice. Pip, any wisdom from you? I'm sure there's lots to share.
Just as Mel said, reflecting on what we've been discussing around the fact that the health professional will be asking lots of questions. My advice to a person with osteoarthritis is do ask your questions, ask them questions, ask what any questions, concerns. Feel free to ask the health professional why they are doing a particular test or what they're looking to find out from doing that. So I think you'll be asked to answer lots of questions, but also do make sure that you ask your questions.
Yeah, definitely be proactive in that engagement and hopefully learn a lot from that and be more empowered as a consequence of that. Now, Mel, Pip, thank you so much for your time, for your valuable contribution, both to the Atlas modules, but obviously also to this podcast and the invaluable contributions you're making to osteoarthritis as a whole and the community of people that we serve.
Thank you very much for having us.
It's a pleasure. So really an important topic today, one that I hope you've gained a lot from and that will help your journey of living with osteoarthritis, particularly as it relates to getting a truly informed and engaged healthcare professional to provide a meaningful management for your disease that will be shaped and formed based upon the information you provide in the history, and ideally telling them about the impact that this is having on your life, whether that be your work, your social roles, your relationships, and identifying with them goals that are meaningful to you. This could be anything, it might be a health-related goal, it might be something around activities that you like to do, participation in the community that you might have, but it should be ideally tailored towards what your preferences and values are and done in a way that is truly person-centered. And from there, a tailored physical examination would occur that ideally respects your dignity and your comfort and is done in a way that's tailored and targeted towards finding out specifically what is wrong with the joint and where your symptoms may be coming from, and to better understand the function of the joint itself. So again, these elements we're sharing today because they're truly an important part of your journey of living with osteoarthritis, and the more forewarned and forearmed you are about that particular journey, the better informed and empowered you will be. So I'm hoping you found today's episode helpful. Again, huge thanks to Mel and Pip for sharing their insights, and to Letitia for their valuable contributions to the Atlas module that they've created. Really hoping that this was informative for you. And again, thank you for your continued support of the Joint Action podcast. And we'll look forward to seeing you hopefully again in the not too distant future. But between now and then, please do take good care of yourself.
Thanks for listening to Joint Action with David Hunter. If you like our show and want to know more, visit www.jointaction.info. If you have any questions, you can email us at hello@jointaction.info and follow us on Twitter @jointactionorg. This podcast was hosted by David Hunter, edited by Vicky Duong, music produced by Jordan Hunter. The information posted on this podcast is not intended to diagnose, treat, cure, or prevent disease. Anyone seeking medical advice should consult a health professional.